Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Welcome, future nurses, to another important area of cardiovascular nursing, valvular disorders. The heart valves play a critical role in maintaining unidirectional blood flow, and when they become narrowed, stiff, or fail to close properly, the heart's efficiency is compromised. Conditions such as mitral stenosis, aortic regurgitation, tricuspid insufficiency, and other valvular diseases can lead to complications like heart failure, arrhythmias, pulmonary hypertension, and reduced cardiac output. In this session, we will dive into the nursing care of clients with valvular disorders, focusing on early recognition of symptoms such as murmurs, dyspnea, fatigue, and edema. We will also cover interventions ranging from medication management and infection prevention to pre- and post-operative care for clients undergoing valve repair or replacement. Nursing responsibilities extend beyond acute care, including client education on lifestyle modifications, anticoagulant therapy monitoring, and long-term follow-up to reduce complications. By the end of this discussion, you will be confident in your ability to assess, monitor, and provide comprehensive care for clients with valvular disorders, helping them achieve better outcomes and improved quality of life. Before we move on to the next NCLEX topic, let me share something that could be the game changer in your journey. If you are determined to pass the NCLEX on your very next attempt, the ultimate NCLEX crash course is exactly what you need. This program has already helped more than 100,000 nursing students achieve success, and now it's your turn. Here is what makes it powerful. Daily interactive live classes, easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks and PDF notes for quick revision, a ready-to-use student planner, and detailed NGN question breakdowns in comprehensive lectures. It is not just a course, it's your all-in-one NCLEX toolkit. Simply scan the QR code now or click the link in the description to enroll instantly. You'll unlock free content like PDF notes, practice tests, and NCLEX quizzes, plus access to our Telegram and WhatsApp groups filled with even more free resources to keep you ahead. Let us now transition into another high-yield NCLEX-style practice question that blends cardiovascular knowledge with infection history. Imagine a 28-year-old client undergoing a pre-employment physical examination who is noted to have a loud systolic murmur at the apex radiating toward the axilla. The physician suspects chronic valvular disease, and the nurse recalls that if this abnormality is secondary to inflammatory damage from a childhood infection, the most likely history would include which condition? Here are the options to consider. Option A is varicella, also known as chickenpox. Option B is rubella, sometimes referred to as German measles. Option C is rheumatic fever. Option D is pertussis, commonly known as whooping cough. The correct answer is option C, rheumatic fever. Rheumatic fever is an autoimmune inflammatory disease that arises as a delayed complication of untreated or inadequately treated Group A beta-hemolytic streptococcal pharyngitis, more commonly known as strep throat. Antibodies produced by the immune system mistakenly attack cardiac tissue, especially the endocardium and valves, leading to leaflet thickening, commissural fusion, and shortened chordae tendineae. Over time, this scarring results in valvular lesions, most notably mitral stenosis, and sometimes aortic valve disease. Clinically, many of these clients present years later with murmurs, heart failure, atrial fibrillation, or embolic events. Roughly 30 to 50% of those with rheumatic fever go on to develop chronic rheumatic heart disease. This condition is a classic NCLEX link between a common childhood infection and serious adult cardiac pathology. Now, let us look at the other options. Starting with option A, varicella or chickenpox, this viral illness caused by the varicella-zoster virus can lead to complications like pneumonia or encephalitis, but it has no role in valvular damage. Nursing focus here is more on infection control and immunization. Moving on to option B, rubella. This viral infection during pregnancy is a teratogen and may result in congenital rubella syndrome with cardiac defects, cataracts, and hearing loss in newborns. However, it does not cause acquired valve disease later in life, which is the distinction NCLEX wants you to make. Considering option D, pertussis or whooping cough, this bacterial infection produces severe coughing fits and potential respiratory complications, but there is no connection to valvular heart damage. Nursing teaching here emphasizes immunization and airway management, not cardiac sequelae. To wrap this up with some exam-focused pearls, always connect untreated strep throat to rheumatic fever and subsequent mitral stenosis. When auscultating, remember that a diastolic murmur at the apex with an opening snap points toward rheumatic mitral disease. Importantly, the preventive nursing role lies in ensuring timely antibiotic therapy for strep throat, which can completely prevent rheumatic fever. Stand coast, pearl. Remember this high-yield chain. Strep throat in childhood leads to rheumatic fever, which then progresses to mitral valve disease. Other childhood infections may have systemic consequences, but only rheumatic fever leaves behind the lifelong legacy of chronic valvular heart disease. Let us now move into a high-yield NCLEX-style practice question designed to test your knowledge of rheumatic heart disease management. Imagine a 42-year-old client with a past history of rheumatic fever who has developed progressive mitral valve stenosis. The physician prescribes nifcillin 250 milligrams orally once daily, and during a teaching session, the nurse is asked to explain the purpose of this prescription. Which of the following responses by the nurse best reflects the rationale for this therapy? Here are the choices to consider. Option A says, this medication will destroy the virus that originally caused your valve disease. Option B states, this medication will reduce the scar tissue that has already formed on your valve. Option C suggests, this medication will prevent dangerous blood clots from forming inside your narrowed valve. Option D says, this medication will protect you from future bacterial infections that could worsen your heart condition. The correct answer is option D. This medication will protect you from future bacterial infections that could worsen your heart condition. Clients with a history of rheumatic heart disease remain at lifelong risk of further valve injury if they experience repeat group A beta hemolytic streptococcal infections. Each infection can trigger an immune response that cross-reacts with cardiac tissue, worsening fibrosis, leaflet thickening, and stenosis. Daily prophylactic antibiotics such as nifcillin, or in some cases monthly intramuscular benzathine penicillin, are given to prevent recurrence of strep pharyngitis. Preventing new infections is essential because every reinfection accelerates valve deformity, increases cardiac workload, and heightens the risk of heart failure. While the drug cannot reverse existing damage, it serves as secondary prevention. Additionally, clients may require special antibiotic coverage before dental or surgical procedures to reduce the risk of infective endocarditis. Now, let us quickly examine why the other options are not correct. Option A is wrong because rheumatic fever is not caused by a virus. It results from an autoimmune reaction following bacterial strep throat, and antibiotics do not target viruses. Option B is incorrect because once scar tissue and calcification have formed, no antibiotic can dissolve or repair this structural damage. Only interventions such as valvuloplasty or valve replacement can address it. Option C is also incorrect, because while clients with severe stenosis or atrial fibrillation may indeed require anticoagulants like warfarin to prevent clot formation, antibiotics such as nafcillin do not have any anticoagulant properties. Here is a set of high-yield NCLEX pearls to remember. Rheumatic heart disease stems from repeated streptococcal infections, not from viral illness. Daily or monthly prophylactic penicillin therapy is crucial in preventing recurrence and subsequent immune-mediated injury. Prophylactic antibiotics are also recommended before invasive dental or surgical procedures in these clients. Most importantly, remember that nefcillin and related antibiotics do not reverse fibrosis or calcification, but they are vital for halting further damage. Finally, clients with advanced stenosis may eventually require surgical valve replacement if they develop symptoms of heart failure or atrial fibrillation. Moving ahead into another critical practice scenario, let us consider a client who has been living with progressive mitral valve stenosis for over 10 years. This individual has been managed with long-term diuretic and digoxin therapy to control pulmonary congestion and atrial fibrillation. But now the condition has worsened, and the client is scheduled for a mitral valve replacement. During preoperative teaching, the nurse wants to assess how well the client understands the procedure. The question is, which statement made by the client indicates the most accurate understanding of mitral valve replacement surgery? Here are the options to think through. Option A says, "My blood will be rerouted through a heart-lung machine during the surgery." Option B states, "The surgeon will insert a stent to widen my diseased mitral valve." Option C explains, "My chest will be surgically opened, but my heart will continue beating during the procedure." And option D suggests, "A piece of vein from my leg will be used to replace my narrowed mitral valve." The correct answer is option A, "My blood will be rerouted through a heart-lung machine during the surgery." This response reflects accurate understanding because mitral valve replacement is an open heart procedure that requires the use of cardiopulmonary bypass. The client's blood is diverted from the heart and lungs, oxygenated externally by the heart-lung machine, and then returned to systemic circulation. This process allows the surgeon to operate on a motionless, bloodless heart, while still maintaining full oxygenation and perfusion to the body. Recognizing the role of cardiopulmonary bypass shows clear comprehension of the surgical technique involved. Now let us break down why the other responses are incorrect. Option B, which mentions stent insertion, is actually a treatment for coronary artery disease and not for valvular stenosis. Mitral stenosis results from fibrosis and calcification of the valve leaflets, which cannot be repaired with a stent. Option C, which suggests the chest will be opened but the heart will not be stopped, does not align with standard practice. For a complete mitral valve replacement, the heart must be temporarily stopped so the surgeon can carefully remove the diseased valve and implant a new prosthesis. Finally, option D refers to using a leg vein to replace the valve, which confuses mitral valve surgery with coronary artery bypass grafting. In valve replacement, either a mechanical prosthetic valve or a bioprosthetic tissue valve is used, not a vein graft. From a clinical perspective, it is also vital to understand what happens before and after this surgery. Before surgery, nurses must prepare the client by explaining the use of cardiopulmonary bypass and discussing the long-term implications of valve choice. Mechanical valves are highly durable but require lifelong anticoagulation therapy, while bioprosthetic valves have limited durability but usually do not require ongoing anticoagulants. After surgery, monitoring for bleeding, arrhythmias, thromboembolic events, and strict anticoagulation management is essential. Clients with prosthetic valves must also be educated about prophylaxis for infective endocarditis since they are at increased lifelong risk. Stancoast. Pearl. Always remember, mitral valve replacement is not a stent procedure, and it does not involve veins from the leg. It requires open heart surgery with cardiopulmonary bypass. And the client must fully understand the type of prosthetic valve, the need for anticoagulation, and infection prevention strategies for the rest of their life. Hey, future nurses! Before we jump into the next NCLEX topic, I want to pause and give you something that might completely change your prep strategy. Imagine walking into the exam room with total confidence, knowing you have the ultimate NCLEX crash course backing you up. This isn't theory. Over 100,000 nursing students have already passed with it. So what's inside? Interactive live classes, binge-worthy recorded lectures, over 5,000 practice questions, 30 full-length tests, ebooks and notes for last-minute revision, a ready-to-use student planner, and NCLEX-style questions explained in detail. This is not just another review course, it's the complete package. Scan the QR code or tap the link in the description right now to join. As a bonus, you'll get free resources like PDF notes, quizzes, and practice tests, plus access to our study communities on Telegram and WhatsApp. Now let us move into a scenario focused on postoperative recovery and energy conservation. A client is on postoperative day 2 following major abdominal surgery. and the nurse notices that the patient becomes short of breath with moderate exertion, such as walking to the bathroom. The physician has approved that the client may sit in a chair if tolerated. But the priority goal for the nurse is to promote recovery without exhausting the patient's limited energy reserves. The question is, which nursing action would best help reduce the client's energy expenditure while still supporting gradual activity tolerance? Here are the options to consider. Option A suggests administering supplemental oxygen only when the client becomes dyspneic. Option B proposes staggering routine self-care activities over several hours with planned rest intervals. Option C offers providing analgesic medications as needed to relieve discomfort during movement. Option D recommends restricting visitors to short, limited periods to reduce environmental stimulation. The correct answer is Option B, stagger routine self-care activities over several hours with planned rest intervals. This is the most effective choice because pacing activities across the day prevents sudden spikes in oxygen demand, reduces cardiovascular strain, and promotes endurance without overwhelming the client's limited cardiopulmonary reserve. Clients with activity intolerance often struggle to match oxygen supply with demand during exertion. So energy conservation techniques, such as spacing tasks, using rest periods, and prioritizing essential activities are key in safe recovery. On the other hand, Option A, administering oxygen when the client is already dyspneic, is reactive and does not prevent the underlying fatigue or oxygen debt. Option C, giving analgesics, is important for pain control and mobility, but does not directly reduce energy expenditure. In fact, some analgesics may further impair tolerance through sedation or respiratory depression. Option D, limiting visitors, may reduce stimulation, but does not directly address physiologic oxygen use. And emotional support from family is often beneficial for recovery. Clinically, the most effective approach is prevention rather than reaction. Pacing tasks reduces fatigue before it happens, while reactive oxygen use or visitor limits only address secondary concerns. High-yield NCLEX reminders. Here include that activity intolerance results from an imbalance between oxygen supply and demand. Energy conservation strategies are central to care, and postoperative recovery should focus on graded mobilization with adequate rest. And finally, remember the Stand-Coast Pearl. In clients with limited cardiopulmonary reserve, the most effective way to reduce energy expenditure is to pace activities with adequate rest, not just to add oxygen. Prevention of fatigue is safer and more therapeutic than reacting to dyspnea once it occurs. Let us move forward with another advanced NCLEX-style practice scenario. A client is on postoperative day 3 following abdominal surgery, and the nurse is carefully assessing whether the patient can physiologically tolerate the activity of getting out of bed and ambulating for the very first time. The nurse must determine which clinical sign provides the most reliable evidence of safety for this step. Here are the choices. Option A suggests that the client's appetite has improved. Option B indicates the client reports more restful sleep. Option C points to the client's heart rate remaining stable with minimal exertion. And Option D emphasizes that the client demonstrates the ability to get out of bed without assistance. The correct response is Option C, the client's heart rate remains stable with minimal exertion. Now let us break this down with a detailed rationale. The stability of the heart rate during activity is the most objective and clinically reliable sign that a client is physiologically tolerating exertion. A steady cardiovascular response without tachycardia, irregular rhythms, chest pain, or hypotension confirms that oxygen delivery to tissues remains effective. Since the cardiovascular system is the key limiting factor in activity tolerance, any instability signals risk for hypoxia or poor perfusion. NCLEX questions emphasize that vital signs and physiologic responses, heart rate, blood pressure, oxygen saturation, and respiratory effort, are the gold standard for judging safe ambulation. Signs of intolerance include rapid or irregular pulse, pallor, dizziness, dyspnea, chest pain, diaphoresis, or severe fatigue. In contrast, Option A, improved appetite, while encouraging for overall recovery, is not a physiologic measure of cardiopulmonary readiness. Appetite is affected by pain, medications, and environment, making it a poor determinant of exertional safety. Option B, reporting restful sleep, may suggest comfort or reduced anxiety, but sleep quality does not directly correlate with activity tolerance. A patient can sleep well and still show poor cardiovascular reserve. Option D, the ability to get out of bed independently, highlights musculoskeletal strength and coordination, but without evaluating vital signs, the client could still experience dizziness, hypotension, or arrhythmias once upright. Clinically, the key application is that nurses must always prioritize objective physiologic measures over subjective improvements when determining readiness for activity. Safety comes first, and monitoring for intolerance signs like tachycardia, hypotension, or dyspnea ensures timely intervention. For NCLEX strategy, remember that cardiovascular and respiratory stability always outweigh non-specific indicators like comfort, appetite, or independence. Stand coast. Pearl. For NCLEX, think of the heart as the truth teller of tolerance. Appetite, sleep, and independence may reflect progress, but only a stable heart rate and vital signs confirm that the body can truly handle the stress of activity. Now let us dive into a therapeutic communication scenario that often challenges nursing students. A client who is 1 week postoperative after undergoing a mitral valve replacement expresses frustration about the slow pace of recovery. During lunch, the client angrily pushes the tray away, and it falls onto the floor. The nurse immediately enters the room after this event. The question asks, which nursing intervention would be most therapeutic at this moment? Here are the choices. Option A suggests quietly cleaning up the floor without addressing the behavior. Option B proposes offering to request a different meal tray that might be more appealing. Option C recommends encouraging the client to verbalize feelings of frustration about recovery. Option D advises leaving the client alone to allow time to calm down before resuming care. The correct answer is Option C, encouraging the client to verbalize feelings of frustration about recovery. The rationale is important to understand. Post-cardiac surgery, clients commonly experience emotional changes such as frustration, depression, and anger due to fatigue, dependence, and the long recovery period. By encouraging expression of feelings, the nurse validates the client's emotions, fosters trust, and uses therapeutic communication skills such as empathy and active listening. Allowing the client to ventilate emotions prevents maladaptive coping and supports psychosocial healing, which is just as essential as physical recovery. On the other hand, quietly cleaning the floor without addressing the behavior, as in Option A, avoids the issue altogether. This silence may make the client feel ignored or dismissed, which is non-therapeutic. Offering a different meal, as in Option B, focuses on food preference rather than the deeper issue of emotional frustration, and therefore does not resolve the core concern. Leaving the client alone, as suggested in Option D, may appear to give space, but in reality, it increases feelings of abandonment and isolation, which can worsen depression or anxiety. From an NCLEX exam perspective, remember the high yield point. When clients are displaying anger or frustration, look for the option that validates and encourages expression of feelings, rather than ignoring, trivializing, or avoiding the issue. This case also illustrates displacement as a defense mechanism, where anger about recovery was redirected onto the meal tray. The therapeutic approach is not to fix the surface behavior, but to explore and acknowledge the emotion underneath. Stand coast. Pearl. In psychosocial nursing care, the heart of healing lies in listening and validating. Encouraging clients to share their feelings is the most powerful therapeutic tool. Hold on a second before we dive into the next NCLEX topic. I need to share something urgent with you. If you are serious about passing the NCLEX on your very next attempt, you cannot afford to miss the ultimate NCLEX crash course. More than 100,000 students have already cleared their exam with it, and you can too. Why is this course different? Because it gives you everything in one place. Live interactive classes, recorded lectures you can rewatch anytime, 5,000 practice-style questions, 30 practice tests, ebooks and PDF revision notes, a student planner, and detailed NGN question explanations. This is your shortcut to success. Don't wait. Scan the QR code or click the link in the description now. You will instantly unlock free study content including NCLEX quizzes, PDF notes, and practice tests, plus access to our Telegram and WhatsApp groups with even more support. Let us now move into our first advanced scenario and break it down in a way that is clear for narration. A nurse is performing a comprehensive physical assessment on an adult client who has a long-standing history of chronic cardiac disease. The question asks, which physical finding would the nurse most frequently expect to observe in this population? Here are the options. Option A suggests a barrel-shaped chest. Option B indicates flushed facial skin. Option C points to clubbed fingertips. Option D emphasizes chest pain. The correct answer here is option C, clubbed fingertips. And to understand why, let us explore the expanded rationale. Clubbing of the fingertips is a hallmark sign of chronic hypoxemia, often seen in clients with long-standing cardiopulmonary diseases, such as congenital cyanotic heart disease, chronic heart failure, or cor pulmonale. It develops as persistent low-oxygen triggers, vasodilation, increased vascular permeability, and connective tissue proliferation at the nail bed. Over years, this leads to the distal phalanx enlarging and the nail angle exceeding the normal 160 degrees, known as the Lovibond angle. The result is a drumstick-like or spoon-shaped appearance of the fingertips. This change is gradual and represents a chronic adaptation rather than an acute episode like chest pain. The presence of clubbing indicates advanced disease and long-term tissue hypoxia. Now let us review why the other options are incorrect. Option A, a barrel-shaped chest, is most often seen in chronic obstructive pulmonary disease, such as emphysema. It occurs due to chronic air trapping, hyperinflation, and loss of elasticity in the lungs, which expands the anterior-posterior diameter of the chest. While a client may have both cardiac and pulmonary disease, barrel chest is not a direct or frequent manifestation of cardiac problems. Moving to option B, flushed facial skin is more likely linked to fever, polycythemia, or hypertension, and is not a persistent feature of chronic cardiac conditions. Chronic cardiac clients more commonly show cyanosis, pallor, or cool skin due to poor circulation, not facial flushing. Finally, option D, chest pain, is indeed common in ischemic heart disease or acute coronary syndromes. However, it is not a consistent chronic manifestation. Long-term cardiac patients are more likely to report dyspnea, fatigue, or edema, rather than constant chest pain. Clinically, assessment of clubbing can be performed using the Shamroth sign, where the dorsal surfaces of opposite fingers are placed together. In a normal hand, a diamond-shaped window appears at the nail beds. When this space is absent, it is an early sign of clubbing. Pathophysiologically, chronic hypoxemia stimulates growth factors such as platelet-derived growth factor and vascular endothelial growth factor, leading to soft tissue hypertrophy in the distal digits. Associated diseases include chronic cyanotic congenital heart defects, like tetralogy of Fallot and Eisenmenger's syndrome, as well as long-standing left-sided heart failure and pulmonary diseases that contribute to cardiac strain. And here is a high-yield Stan Coast pearl to remember. Clubbing is the fingerprint of chronic hypoxemia. When you see it, think years of cardiopulmonary compromise, not just today's chest pain.